Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman. I would like to extend my sincere gratitude to the organizing and scientific committee for inviting me, for giving this great opportunity to give a talk on the impact of obesity on fasting. I would like to thank a special thanks to Professor Muhammad Hassanin and his hardworking groups for their tireless effort on working and bringing together those brilliant minds on discussing different issues related to the fasting of Ramadan in the diabetes population. I'd like to also give a special thanks to the group of Dar Mina who participated in making this survey happen by distributing it to their patients. So in the next 15 minutes, I'll be going through the data cross-sectional survey, which was conducted to assess the fasting practices among people with type 2 diabetes during Ramadan 2020 and Ramadan 2022. The primary objective of this survey was to describe the characteristic and current patterns of care for patients with type 2 diabetes during and after Ramadan for both those two periods. The demographics, biochemical, and fasting characteristic of type 2 diabetic patients who participated in this DAR global survey of 2020 and 2022 were stratified based on the BMI data. Participants were divided into two groups, South Asian group, including around 2,000 plus patients, and non-South Asian group, including 4,400 plus patients. And the reason behind the dividing them into two groups, as we are aware that the patients from South Asian region basically considered to have obesity with a lower BMI. So they are considered to be obese if their BMI is 28 and above. So let's start by getting into describing the demographics of the non-South Asian group, which basically includes countries from the Middle East, North Africa, and the Gulf region. So as you can see on the screen that the distribution was equal among the different BMI categories, and it was very obvious that the patients with higher BMI considered to have a higher percentage of hypertension and microalbuminuria. But if we dig into the data further, we find that also very interestingly in this non-South Asian group, that the group of patients with overweight who were not obese had a higher percentage of high LDL as well as the microalbuminuria. And if we look at the distribution of medication usage by BMI group, it was very obvious that the patients with obesity were more likely to use GLP-1, and that was statistically significant compared to the group of normal weight. The other thing also was the use of the SGLT2 inhibitor was more common in the group of patients of obesity and overweight. So the SGLT2 and GLP-1 usage was increasingly used in patients with the higher BMI groups, reflecting their dual efficacy in managing diabetes and obesity. And very interestingly, of course, metformin remains the cornerstone therapy across all BMI groups, while the usage of insulin type varies with increasing insulin resistance in the higher BMI patients, highlighting the greater prevalence of GLP-1 and SGLT2 use in obese patients, which could demonstrate the shift towards weight-centering diabetes management. The use of sulfonylurea, despite its diminishing role globally, shows continued relevance in this population, particularly in the mid-range BMI groups. And if you look at the fasting characteristic or the fasting intention, and if we try to characterize this across the different BMI groups, we can see that those patients were equally distributed. There was no difference in terms of their intention to fasting of Ramadan, or even intention of fasting of Shawwal, was not different in between different BMI groups. But then if we look at the hypo and hyperglycemia, we found that the hypoglycemia of more than 8 days was more statistically significant in the group of patients who were BMI with less than 25, while the hyperglycemia was more common in the group of patients with BMI of more than 30, which tells you that the fluctuations of the glycemic control is different in different BMI groups. What about the self-monitoring and education by BMI group was not different, but we found that those who had an overweight category were more likely to do SMBG monitoring compared to the other groups, although the end result was not statistically significant. Shifting gears toward the South Asian group, which includes basically South Asian countries, and let's look at their characteristic. We found that it was almost similar to the non-South Asian group, but more in terms of the prevalence of the retinopathy and microalbuminuria, as well as the duration of diabetes of more than 20 years. So what we found that the higher the BMI group, they had higher percentage of the hypertension, as well as microalbuminuria and retinopathy. What was interesting in terms of the medication use in this group of the South Asian countries, they still were using the GLP-1 more in patients with the obese category, and the use of SGLT2 inhibitors was more common in the obese category of this population compared to the non-South Asian population. We also found that the South Asian population were more likely to use the DPP-4 inhibitors if they were obese, as well as the insulin intermediate acting, which might indicate the insulin resistance in this group. And if we look at the fasting characteristic by BMI group in the South Asian population, we can see that the intention to fast Ramadan or Shawwal was slightly higher in the obese category, but it did not reach the statistical significance to say that the obese patients were more likely to fast Ramadan versus the non-obese patient. But very interestingly, if we look at the hypo and hyperglycemia in this South Asian group, and this was that was different in the non-South Asian group, we found that the hypoglycemia was more highly significant in the group of lower BMI, which is still the same case in the South Asian group. But the South Asian group also, the lower BMI, not only experienced the hypoglycemia, but they were statistically significant to experience more hyperglycemia compared to the obese group, which tells you that maybe they are more prone to have high fluctuations of their glycemic control in according to their BMI. What we also found that was statistically significant, that the group in South Asian group, that the overweight and the obese category in this population were more likely to receive education in the clinic compared to the normal weight in this population. But on the other hand, we can see that the normal BMI were more likely to do more frequent SMBG, and they were more likely to receive education in groups, which tells you most likely that this group, including patients with type 1 diabetes, who are most of the time can receive education into groups, and they're more likely to do SMBG monitoring during fasting in Ramadan. And if we try to do a comparative analysis and look at if there was any difference between the South Asian versus the non-South Asian group in terms of their demographics or practice, and I really truly apologize for the busy slide, but if for any of those categories, the last three bars on the left side basically describes the South Asian group, and the right three bars describe the non-South Asian group. And as you can see that they are equally distributed. There was no major difference apart from that we have seen much more percentage of hypertension and higher LDL in the South Asian group, in the South Asian obese and overweight group. And if we look at the use of the medication, we can see that the metformin still remains the cornerstone of treatment in either of those population. But the use of the SGLT2 inhibitors was more common in the non-South Asian population compared to the South Asian population in terms of the percentage, and as well as the GLP-1 was more common to be used in the non-South Asian population compared to the South Asian population. And if we look at the hypo and hyperglycemia, we can see that the hypo and hyperglycemia percentage was basically much more common in the group of the South Asian normal weight, which basically are likely to indicate that they were type 1 diabetic patients. Other than that, we can see they are equally distributed. There was no differences in terms of the hypo or hyperglycemia in those population if we compare them according to their BMI. And the emergency room visits were kind of slightly higher related to the hypoglycemia in the population of the non-Southeast Asian compared to the population of the Southeast Asia. Apart from that, if we look at the education, we did find that the non-South Asian group actually were not doing SMBG likely more compared to pre-Ramadan versus the group of the Middle Eastern or the non-South Asian group were likely to do more frequent SMBGs. So in conclusion, we can say that the data basically shows a high intention to fast during Ramadan across all BMI groups. Fasting is a deeply ingrained practice. Looks like it's unaffected by BMI. Slightly higher percentage of participants fasting the full day, 30 days in the BMI of more than 30, may reflect increased motivation to engage in religious practices or improve health outcomes, higher inclination for post-Ramadan fasting in the higher BMI groups, which could reflect cultural and individual motivation that merit further exploration. And also, as I mentioned, that the higher prevalence of hypoglycemia in patients with BMI that is less than 23, which is likely indicating this where type 1 diabetic patients will definitely benefit from using advanced technology like sensors and automated insulin delivery system. With this, I would like to thank you for listening. And we are looking forward to talk with you and answer your question during the discussion period. Thank you.